Hi, Dr. Choll Kim here from San Diego and the North American Spine Society, and I'm with one of my favorite surgeons. He is a bona fide pioneer and leader and a bit of my hero. He's from Texas Back Institute, Dr. Rick Geyer, and he does everything well, but one of the things that he does really well is lumbar disc replacement surgery. So spine is a little weird because it's one of the few specialties where we still do fusions. So back in the day, I guess we did fusions in the knee and the hip. We hardly ever do that anymore. They're all motion preservation replacement devices. So it just makes sense that eventually we'll want to do the same thing for the lumbar spine. And when it first came out about 20 years ago in the US, everyone was a little scared that it's going to wear out, loosen, and we're going to have a catastrophe. But Dr. Geyer has been sticking with it, and he has a vast experience with this procedure, and the results have been pretty amazing. So can I ask you, just right off the bat, from a patient's perspective, when they're considering fusions, they're miserable, you've identified the level, you want to do a disc surgery for back pain. Surgeon versus disc replacement, fusion versus disc replacement. From a patient's perspective, what should I be asking? What should I be concerned about?
Okay. Well, there's several things that go into this decision making, whether or not you're a candidate for disc replacement. And the spine is very, very complex. And if a patient has instability, which means abnormal motion, no, they're not a candidate for disc replacement. If they have a significant deformity, they're not a candidate. That falls under the scoliosis treatment. However, if they have back pain, and I'm just not talking about a little bit of back pain. This is people who've suffered for years and years. They've gone through all the conservative treatment, such as physical therapy, injections, activity limitation. And typically I'll ask my patients, well, what happens in the morning? How do you get out of bed? Can you just brush your teeth okay? No, I have trouble brushing my teeth, and it takes me an hour of stretching to get moving. And they really have been through everything, and they've given up many, many things in life. So there's a difference between just the run-of-the-mill back pain, which usually 99% of that we can handle with the right exercises. But for that small percent that are miserable, and there are a lot of people out that are miserable or had a previous discectomy, the disc replacement is an ideal solution. Now, you mentioned that in the beginning we were worried about the longevity. We just published a paper with 20-year follow-up that showed that the revision rate, which means going in there and doing another operation at disc, was 1.26%.
That's astounding.
And 40% of those were in our first 25 patients, our learning curve, when we started back in 2000. So we've been doing them since March of 2000, 24 and a half years. And the interesting thing is that our data has been also reported very similarly by Terry Marnay, the inventor of the ProDisc, right, artificial disc, at less than 1%. So he and I joke about it at meetings. So from the patient perspective, if you had a total hip or total knee, they would tell you that the longevity of it at 20 years is about a 10% revision for the knees and 15% for the back, whereas the lumbar spine disc replacement is less than 1%. So it is long lasting, and all the things we worried about was horrible revision. They're just not happening. So once you get it, it's going to last a long time. They're tested to last 40 years. Patients say, how long is it going to last? And I say, well, they're tested for 40 years, and we're at 24 and a half years, and knock on wood, we're still going strong.
And what's amazing is that the data is so solid. It is real life data. You can't fake a revision total disc replacement surgery. So I think everyone's pleasantly surprised, markedly surprised, people like me, at how well they're doing long term. And I've completely changed my outlook on it. Tell us about what the experience will be like for a patient that has, that's looking at a lumbar disc replacement. Like, how long do they stay in the hospital?
Okay.
What's their first month look like when they are at home, et cetera?
Well, we use a minimally invasive approach, which everybody knows what that means. That means not destroying soft tissues. We come in through the stomach, and people think, oh, you're going through my stomach. No, we go in between the muscles. We use an access surgeon here in the US. In Europe, a lot of them do their own approaches, but we use access surgeons. It is a small incision about this big for a single level, either vertical or horizontal, depending if it's a male or female, and if they want to a cosmetically acceptable incision. But the incisions heal very, very nicely. The rectus muscle, which are known as the six-pack muscles, which are buried somewhere in here, we go underneath and we go inside the abdominal wall and pull the whole contents of the peritoneum or the sac that holds all your organs. So basically, a patient is only in the hospital overnight. They have very little pain other than the incisional pain. So most of our patients are discharged by noon the following day. They're up and walking around. They can drive a car a week. At 2 weeks after surgery, they start physical therapy. If they have, a non-laboring job, they can go back to work in 2 weeks, or a lot of them work from home. They're already on the, on the internet working the following week. If they have a more heavy job, then we say 2 to 4 weeks. And if they are, have an office job at 6 weeks, we'll let them slowly get back to activities. If they're a golfer, we'll let them start to chip and putt. And at 3 months, we let them go back and do everything, because by 3 months, we know that the implant is now fused to the bone. And there's different ways of fixation. We have spikes and we have keels to keep the disc stable immediately after surgery. But the bone will grow into the implant, and that anchors it permanently. And that's why we have such good long-term results. But after 3 months, patients say, well, can I do this? Can I do that? We don't have any restriction. They do anything.
That is an amazing rehab program. That's even faster than what I remember, and it makes sense. All surgeries have risks. So if I was afraid of something, what would be the most common potential kind of risks, complications, heaven forbid, that a patient might experience?
Well, the most common things that we see, first of all, our access surgeons are very, very good. So there's always a risk to the blood vessels, but it's extremely rare. The most common thing that we see is about 10% of patients will get, for want of a better term, we don't have another term for it, we call it postoperative nerve stretch pain. And it can occur whether the disc is totally collapsed or if it's only mildly collapsed. But patients get this vague leg pain. It's not accompanied by any weakness or numbness. It's just this aching. And it tends to be worse at night when all your sensory input is shut down. During the daytime, they get up and walk around, they feel better.
They get better over time. They get used to it.
They get better over time. And we now do a protocol where we start them on medications to lessen that effect. And if at 2 weeks they don't have any problems, we just stop it. The other thing, and it's sort of, there's a lot of misconception about it. Males say, oh, well, I heard you can get impotent. That is totally false. There are some little nerves in the front of the spine that can sometimes get bruised, and these affect the ejaculation of a male. So instead of it going to the outside, it comes into the bladder. But the patient is not impotent. They are not sterile. They can still make babies. And in 50% of the time, it gets better. It occurs in 1 out of 200 patients, and 50% get better over time. So it's extremely rare.
And then out of all the surgeries that I do, there's a few surgeries that I find very technically demanding. And one of them is putting in a motion device. So when I do a fusion, the implants don't necessarily have to be perfect, because once the bones heal, it doesn't matter where the implants are, because the bones take over. But a motion device has to continually function, and it's under continuous strain because the bones don't take over.
I get what you're saying. You're right. So placing a lumbar artificial disc is very, very precise. There were some early studies, and I don't necessarily agree with this. It said as long as you were within 3 millimeters of midline. I try to make mine perfect every time, okay?
Of course you do.
Because, we don't know what the long term is going to be. And for that disc to function perfectly, you want it to be balanced in both sides. Because if it's off to one side, in 5 or 10 years, the patient may develop a curvature. Now, has it happened? On occasion, sometimes even if it's totally centered, but you don't want to give the patient an opportunity to have anything go awry. So you really want to make it perfect. In fact, in the OR, they have a joke. It's called a Geyer unit. A Geyer unit is somewhere between a millimeter and a micron. So, and they say, oh, that's half a Geyer off. But I am a perfectionist. I try to make them look as perfect as I can.
This is why I love you. And I think it's important that there's some procedures that should be done by somebody that's really experienced, has a lot of practice putting a lot of these in. So would it be fair to say that a patient that's considering a disc replacement should talk to somebody that does a lot of disc replacements.
Oh, absolutely.
Because it's a technically difficult surgery.
It's like that with any surgery. I mean, I've had a couple surgeries myself, and I always sought out the person that did the most. But,
Right.
but your point is well taken. You need to have somebody that does them. And unfortunately, a lot of surgeons don't do them. They'll say, oh, well, they don't work or they fail, and which is totally erroneous. That was, 20 years ago. But when that kind of talk was going about. But it's now proven technology. It's a successful technology. The patients, if chosen right, are so grateful. And repetitively, I hear, Dr. Geyer, you gave me my life back. And to me, that's the most gratifying thing, to know that I've done an operation on them that is going to be long lasting. And they're not going to have to come back for another fusion, and another fusion. And it's beyond my expectations, as you started saying in the beginning when we started. I had no idea.
Well, I wonder if the great results are because the people that stuck with it are surgeons like yourself. I suspect that's the case, because when you have a bunch of dedicated experts focused on a specific field, I think the overall results are going to be a lot better than when a bunch of different people try to do the surgery kind of a little bit at a time or intermittently. So once again, I thank you for all that you do. We appreciate you. And Dr. Geyer is, in many ways, is going to change the way we take care of our back patients in the coming future. And it's certainly changed the way I look at patients with low back pain now. So thank you very much.
And thank you, Choll. This was great. And I hope everybody takes it in and can make good decisions for themselves in the future.
Absolutely.